Hello, and thank you for joining us today for Breast MRI 101, Understanding Indications and Uses. As a reminder, all lines will be muted. The presentation will be recorded and provided via a follow-up email. This event is brought to you by the Samaritan Cancer Resource Centers. Our mission is to partner with anyone touched by cancer to provide the support they need to live with strength, determination, and hope into the future. Please enter your questions in the Q&A box, and it's at the right-hand side of your screen. Your questions will be answered at the end of the event, and we'll be monitoring the questions throughout the duration of the seminar, and time will be reserved at the end of the presentation to address these questions. A link to a survey will be provided within the Q&A and chat box, so you may give us your feedback regarding today's presentation. Today, we are pleased to have Dr. Germino as our guest.
Jessica Germino, MD, received her undergraduate degree from the University of Chicago, her medical degree from Washington University in St. Louis, Missouri. Following a residency in diagnostic radiology at the University of Washington in Seattle, Washington, she completed a fellowship in breast imaging at the University of Washington, Seattle Cancer Care Alliance. Dr. Germino is the director of breast imaging at Corvallis Radiology and Samaritan Health Services. She works with patients at Pacific Communities Hospital, North Lincoln Hospital, Lebanon Community Hospital, Albany General Hospital, Valley Imaging Services, and Good Samaritan Regional Medical Center. Her clinical interests center around access to mammography with the goal of increasing utilization of screening mammography in our community and promoting early breast cancer detection. It is now our pleasure to turn this presentation over to Dr. Germino. Thank you, Dr. Germino.
All right, and thank you both, and thank you everyone for having me here today. It's October Breast Cancer Awareness Month, and I'm very happy to chat with you all. I have no financial disclosures for this talk. Today, I want to talk about basics of breast MRI. We can think about this as the 5 W's of breast MRI. What, why, who, when, and where. Before we get started, there's some vocabulary that I want to go over. You're going to hear me say some terms that have a precise meaning when we talk about medical tests. And since MRI is a form of test we use for breast cancer detection, you're going to hear me talk about sensitivity. That is a measurement of how often a test can correctly generate a positive result for people who have the condition. You might hear about this as the true positive rate. So can a test detect what it's looking for? How well does it do that? Specificity measures a test's ability to correctly generate a negative test result for people who don't have the condition, the true negative rate. For example, a mammogram. If it tells you that you have a normal mammogram, a high specificity would be obtained if you do not have breast cancer. It's showing you a true negative rate. So a good test. No test is going to be 100% sensitive and specific. We're going to have trade-offs. Tests that tend to have high sensitivity may have false positives. It's when healthy people are incorrectly shown to have the disease. That's a false positive. A high specificity or highly specific test may have false negatives. That's a test that finds people with the disease, people who have the disease are missed by the test. So false negative. So we'll start with our first W, what? What is an MRI and how is it used to look at breast tissue? MRI stands for magnetic resonance imaging. Essentially, The tube of the MRI, as you can see in this cartoon, creates a powerful magnetic field, and it uses technology from radio waves and computers to produce detailed pictures of the inside of your body. These radio waves realign atoms in your body called hydrogen that are normal in your body. By doing this, it does not cause any changes to your tissues or in the chemical nature of your tissues. What it does is it then listens to those hydrogen atoms as they relax or go back to their usual alignment. And when that happens, some energy is emitted, and the technology that we have for MRI can then gather information from that about the type of tissue that those atoms are in. And that's how, with computers, it can recreate all of that information into a picture that we can use for medicine, for medical imaging and diagnosis. MRI differs from X-rays or CT scans in that it does not use X-rays, so there is no radiation in this process. So as we have finished an MRI on a patient, our computer processes all of these signals, creates the images, and each image is a thin slice of the body. So myself as a radiologist, I can scroll through the breast tissue. As you see in this picture, we have breast tissue, 2 breasts. One of them has a lot of green, red, and blue. That shows an abnormality detected on MRI in that breast. With MRI, we can often tell the difference between diseased tissue and normal tissue better than we can with X-rays, CT, or ultrasound. Our next W, why? Why is MRI used to image the breast, and what makes it different than mammography and ultrasound? We find that MRI has the highest sensitivity of breast cancer. One paper found that this high sensitivity is based on the fact that no breast cancer can grow beyond 2 millimeters, which is really tiny in size, without creating new blood vessels that provide sufficient nutrients for the tumor to grow. Those new blood vessels are what we can detect with MRI, because what we're looking at in the tissue is how blood flows. We give you a contrast material, a contrast dye in an IV that traces the blood flow. So new blood vessels, they can be kind of leaky in tumors, and they can show up, like in this picture, as a spot of enhancement or a bright spot in the MRI, and may indicate a breast cancer. So in addition to being sensitive for detecting breast cancer, studies have also shown that MRI is specific too. Compared to mammography, the specificity has been estimated in the high 90%, although it's pretty good for mammograms too, at 92%. As I was hinting at earlier, MRI is useful for the detection of abnormalities in the breast because it is an imaging technique that allows us to look at the function of the breast tissue. Those leaky blood vessels that tend to grow in breast cancers can be detected with contrast a high proportion of the time. And so that's why with MRI, we're able to look at function. Here in this image, I have another example for you. You're going to see that there are 2 breasts imaged, one of which has colors projecting over it. That is a tool that we use when we interpret a breast MRI that allows us to look at the patterns of blood flow. We call it kinetics. And a computer program puts these colors onto our MRI images to help us visually assess how quickly blood flow is coming into the breast and how quickly it washes out. So a breast radiologist will take all of this information, the anatomy of the tissues, which are shown really well by MRI, as well as the functional information, the color map we have here, to interpret the breast MRI. I want to just pause for a moment and tell you that MRI, while a great tool, is not a substitute for mammograms. It is there to supplement or add to mammography. We know from large studies that mammography is the breast imaging tool that's demonstrated with screening to save lives. Mammograms are also very important because they're widely accessible and affordable, and they are the bedrock for breast cancer detection and screening. I wanted to share with you a picture of one thing that mammograms are especially good at that ultrasound and MRI may not be able to see well, and that is calcium in the breast. This is a picture of a mammogram, and in the upper right-hand corner of the picture, you'll see fine, bright dots that look like someone dropped coarse bits of sand onto the mammogram or salt. Those are calcifications, and calcifications can represent early breast cancers. Mammogram is the best way for us to detect these calcifications. So mammogram again is really the foundation of our screening with MRI as a supplement in eligible women. So that brings us to our next W, who? Who is eligible or appropriate for imaging with MRI? There are many guidelines out there with respect to MRI, but the recommendations for women with high risk are pretty clear. Those who are at high risk of breast cancer, greater than 20 to 25% lifetime risk, are recommended for screening with breast MRI as a supplement for mammography, and that comes from the American Cancer Society. You may find that your doctor orders an MRI in other situations. In some women, those with a new breast cancer diagnosis may have an MRI if it will help determine how much breast cancer is in the breast. For instance, if it's suspected that mammogram and ultrasound are not showing the full picture. And if there is a strong family history or other concerns for risk of breast cancer in the other breast, MRI can also be used at that same time to screen the other breast for cancer. In some women who have breast cancer and are taking chemotherapy to shrink the tumor before having surgery, MRI may be ordered by your oncologist to evaluate how you're responding to the chemotherapy. Is the tumor shrinking and how much? Mammogram and ultrasound in this setting are not always clear because as the tumor shrinks, there can be some scar tissue or other changes to the breast around it that are difficult to tell if it's residual cancer or just changes from treatment. So MRI can be useful in this setting because of the contrast and our ability to look at how the breast is taking blood flow or the function of it to determine response to those drugs. In some women, you may have MRI to look for symptoms, a cause of symptoms, when mammogram and ultrasound have not provided a clue to what is causing those symptoms. Most commonly, this includes changes to the nipple, such as nipple retraction or pulling in of the nipple, or nipple discharge. Bloody nipple discharge is a suspicious finding. Clear nipple discharge, like watery, is also. And so when women present with nipple discharge, we often start with mammogram and ultrasound, and if an answer is not found by those techniques, an MRI is recommended as well as a surgical consultation to discuss the symptoms with a breast surgeon. Rarely we have a situation where a cancer is found in the body, typically in the lymph nodes in the underarm, and we do an MRI to try and find a hidden breast cancer or an occult, as we say, breast cancer. So someone may have enlarged lymph nodes and have a normal mammogram and ultrasound. If the lymph nodes showed a cancer in them, we would do an MRI to try and determine if the cancer is coming from the breast. Finally, there is an indication by the Food and Drug Administration to evaluate silicone breast implants for rupture. I will get into the details of that recommendation later on. And this is something that is periodically recommended to ensure that the silicone implant is still intact. We use MRI. As I mentioned earlier, the American Cancer Society has recommendations on screening with breast MRI. We really reserve screening with breast MRI for women who have risk factors for breast cancer, putting them in a higher risk category for developing breast cancer in their lifetime. As I mentioned before, the American Cancer Society recommends screening supplemental to mammography if you have greater than 20 to 25% lifetime risk of breast cancer. Oftentimes, your doctor or your radiologist may be cued into your risks because of a strong family history of breast cancer. And this risk is calculated by various risk assessment tools that are available that your doctor can use to determine where your risks may fall based on a number of questions about your family history and some personal information such as your first period, if you've been through menopause, and other questions that can help us determine your risk of breast cancer. Women who have a known BRCA1 or 2 gene mutation, women who have a first-degree relative, so mother, father, brother, sister, child, with one of the BRCA mutations, and the patient themselves has not had testing. If they have that first-degree relative, they would be eligible. Women who have had radiation therapy to the chest. Most commonly, we would see this chest radiation in childhood and early adulthood with lymphoma. If radiation to the chest at that young age, we know that those individuals are at an increased risk of developing breast cancer because of that exposure to radiation at a relatively young age and breast development. Multiple other syndromes and genetic conditions are also associated with an increased lifetime risk of breast cancer. Here are some listed. These individuals, or those with first-degree relatives with one of these syndromes, should look into whether or not breast MRI would be recommended for them, as there are indications there. Relatively recent studies have also indicated that women who've had a personal history of breast cancer and who have dense breast tissue may benefit from screening with breast MRI. This is primarily in women who were diagnosed before age 50 with breast cancer and have dense breast tissue. They could consider supplementing annual mammograms with breast MRI. The picture here is a mammogram that I'm showing you just as an example of what dense breast tissue looks like. The light gray and white area of this breast is what's called density. The dark gray around it is breast fat. In this person, they have extremely dense breast tissue. And basically what that means is they have a lot of breast tissue compared to breast fat, which means that some masses or tumors can be harder to detect on mammography because of the dense breast tissue. I wanted to circle back to the issue of nipple discharge. Historically, before breast MRI was fully developed, galactography or injection of dye into the nipple was done with women in compression for mammogram to look at how the ducts fill with fluid. Here's an example of that. It's also called a ductogram. This has really fallen out of favor because MRI has been developed and is very sensitive, as we talked about, and specific. And so at this point, recommendations are for women with nipple discharge that's suspicious without a reason identified on mammogram or ultrasound, that MRI be performed to help identify potential source of nipple discharge. So when should MRI be done? Is it different depending on the individual or the clinical situation, the symptoms? It does depend on why you're having the MRI. If you have a new diagnosis of breast cancer, to define the amount of breast cancer and screen the other breast, you should have the MRI as soon as possible. If you have a diagnosis of breast cancer and have already had a breast MRI, your oncologist may want to see how the breast cancer is responding to chemotherapy. And so the order, the time it's ordered or when the MRI is scheduled is really at the discretion of your oncologist. Your oncologist may change or reconsider treatment if depending on your response to medications. And so if you have one of those MRIs, usually your oncologist will decide when it should be done. If you're having symptoms like nipple discharge, but you do not have a diagnosis of breast cancer, you should still have the MRI as soon as possible. Before menopause, typically we do recommend timing the MRI to the phase of your menstrual cycle to try and decrease the distracting blood flow of normal breast tissue, which can be increased, it's thought, at certain times of your menstrual cycle. However, not every woman is regular in their menstrual cycle, and so my preference is not to delay your MRI if that's your case. If we can time it with your menstrual cycle, day 7 to 14 ideally, and it's not a delay in your treatment, that's ideal. However, my goal is never to delay having an evaluation. So if you have a very irregular cycle, you'd want to let your doctor know that ahead of time. This gets to high-risk screening. Since there's no symptom with high-risk screening, we do try to time the MRI to day 7 through 14 of your menstrual cycle. Again, if you're highly irregular and it's just difficult to predict, you should let your doctor know. If you're postmenopausal, then any time is fine. We won't be timing to the menstrual cycle, so you can have your MRI when best timed for your own purposes. For screening of silicone implants for rupture, if you do not have any risk, if you're not considered high risk for breast cancer and you don't have a personal history of breast cancer, we do the MRI without an IV, without contrast. And because of that, it can be done at any time. If you do have a personal history of breast cancer or are considered at high risk of breast cancer in your lifetime, contrast will likely be used or injected for this study, and so we may need to take in some timing considerations. And here's the final word I wanted to discuss on silicone implant evaluation, as I mentioned before. There are recommendations by the Food and Drug Administration regarding screening silicone implants for rupture. At this point, the recommendation is screening 5 to 6 years after surgery and then every 2 to 3 years afterward for those without symptoms. Screening is theoretically possible with ultrasound. My preference to exclude rupture is MRI if I had to choose between the two. If you have symptoms from your implants, though, you should talk to your doctor, or if you are still seeing a plastic surgeon, talk to your plastic surgeon, as they may want to get an MRI sooner. Our final W is where. Where does Samaritan offer breast MRI? We offer breast MRI in Corvallis, and we have 2 different MRI scanners. One is at Good Samaritan within the hospital in the radiology building, and the other is in the Neville building, which is across the street from the hospital. In the hospital, it's a magnet that has a less strong magnet, but it has a larger tube for the body to fit in. So those are ideal for women who need a larger tube for body comfort, claustrophobia, or certain medical devices like pacemakers that are conditional for MRI. So some women with pacemakers may have a pacemaker that is considered okay for MRI in certain situations. That would be in the 1.5 magnet in the hospital. Now, not every pacemaker can have an MRI. Not every person with a pacemaker can. But the 1.5 for certain medical devices would be often the choice. The stronger magnet is in the Neville building, and we do a large number of our breast MRIs there. It is a smaller tube, though, for the body to fit in. I want to thank everyone for your time, and I would be happy to take any questions if you have any regarding my talk. Thank you.
Thank you so much, Dr. Germino. That was very informative.
Just a second. So thanks, Dr. Germino. Please write your questions and comments on the Q&A box. And while you are typing, we'll go over some important points. Samaritan offers mammography services, and you can call or visit the website on your screen for more information. For those in Albany, we are pleased to announce that Samaritan Valley Imaging have extended their appointment hours until 8 p.m. Monday through Thursday. Evening appointments will be for screening mammography only. If you'd like to obtain more resources and information about cancer, feel free to contact our Cancer Resource Centers by phone, email, or visit our website. The Cancer Resource Centers provide monthly virtual education events on cancer-related topics. If you're interested in upcoming events, please contact us to subscribe to our Cancer Resource Center newsletter. We have a couple of our upcoming events that you can see on your screen right now. If you're interested in joining an upcoming virtual Healthy Minds, Healthy Bodies seminar, please visit the email address on your screen. And now, let's go over your questions.
We do have one question in the chat box. Is regular breast MRI indicated in addition to annual mammogram if breast cancer was missed on a mammogram?
Not necessarily. That's a very good question. Many of when we say we recommend MRIs for screening, those recommendations are based on large expert recommendations or consensus recommendations or on large studies. But there may be other reasons that one does pursue breast MRI for screening. In very individual cases, I would encourage you to talk with your oncologist to determine their thoughts on what sort of benefit you may get. If a cancer was not seen on mammogram, so occult or not visible on the mammogram, but was treated and there's no evidence of recurrence or coming back, and you're back into regular screening, I don't think that we can say definitively MRI should be done. But a conversation with your oncologist is recommended to look at the individual details of your situation.
Thank you. We do have one more. This is probably on a lot of people's minds. Is MRI covered by regular health insurance? I'm assuming they mean commercial insurance.
That is a great question. So there are so many insurance companies there. Typically, I have noticed that screening MRIs are covered when one falls into the recommendations put forth by the American Cancer Society. So that was, I'll just go back to that slide if that's okay, just to remind you of what those are. This is from the American Cancer Society here. Who is recommended for screening with MRI? And so that includes greater than 20 to 25% lifetime risk, genetic conditions that we talked about, first degree relatives with the BRCA1, or other BRCA2 and some other genetic conditions in women who have not had such genetic testing themselves. So that sounds a little confusing, but an example would be, my sister has a genetic condition, for example, BRCA1, but I have not been tested. I would still be eligible. And radiation therapy, so to the chest between age 10 and 30. So if a woman has questions about whether or not your specific insurance company would approve it, it may require an order from your doctor with confirmed pre-authorization from your insurance provider, and talk to them if you had any questions. I don't have the deep knowledge of insurance companies and the specifics of how they vary. Generally, I've seen pretty consistent coverage when it comes to screening recommendations put out by the American Cancer Society.
Great, thank you. We don't have any more questions at the moment, but if anyone here has questions after the talk, please feel free to email us at cancerresourcecenter@samhealth.org.
Your feedback is valued. If you could please take a moment to complete the brief survey, which is now available in the chat area or the Q&A. Please take some minutes and send us your feedback. Watch for the follow-up email that will include a link to the recording. With all that said, thank you, Dr. Germino, for your time and sharing your knowledge. And thank you, everyone, for joining us today. And have a great day.